Okay, welcome everyone to tonight's presentation. The speaker is Mr Rohan Thakkar. He's trained in cancer surgery at the Tata Memorial Hospital in India before completing a fellowship in hepatopancreatobiliary transplantation at Newcastle, where he's now a consultant. So his clinical interests include minimally invasive surgery, transplant oncology, and the management of liver and biliary tract tumours. Mr Thakkar is deeply committed to patient safety and has a strong interest in education, both training future surgeons and in empowering patients through education about their care. So we're delighted this evening that Mr Thakkar has agreed to give up some of his precious time to give us this presentation. Excuse me. And we look forward to hearing what he has to say. So may I now hand over to Mr Thakkar.
Thank you. Thanks everyone for attending, and thank you for the kind introduction. So I'll be very honest. I'll set your expectations right. It's not going to be very long because this is a new thing launched in 2022. But I'll give you the reasons why we're doing it and what options are available and where we are at now, and what other countries are doing it and some evidence to support that. It will be very medical. You can always ask questions after. Okay. Okay, I'm just going to start sharing my slides. Give me a second. Okay. Can everyone see the slides?
Yes.
Okay. All right. Let's start from the beginning. So my topic today is liver transplantation in colorectal liver metastases. I'll give you a little background of the burden of colorectal liver metastases and how the patients suffer from liver metastases with colorectal disease. So about 15 to 25% of patients that have colorectal cancer will develop liver disease at the time of presentation, which is called synchronous liver disease. And unfortunately, only a quarter of them will be treatable. In the next 3 to 5 years, about 50% of patients who didn't have liver disease before will develop colorectal metastases. So we're looking at quite a proportion of patients that either present with or develop liver metastases during the course of the disease. Unfortunately, even if we treat them, about 50 to 60% will recur or spread elsewhere. And the reason why we offer treatment is because without any curative operations or curative treatments, palliative chemotherapy, the 5-year survival is only about 14%. And the median survival is only about 25 to 28 months. So the curative options, it's a multi-modality approach. It's not one single modality alone. And the reason why we try and offer any curative strategies is because the survival for 5 years after offering these modalities of treatment is about 42%. In general, there are about 150,000 cases of colorectal cancer per year in the UK, and about 70,000 will develop liver metastases. And this is including both, as I mentioned earlier, at the time of presentation and after some time, 3 to 5 years, which is also called metastasis disease. 45,000% will develop liver only or liver first metastases, and about 2,000 to 4,500 will have an operation. So you're looking at big numbers, but a small percentage. Why do we offer a major operation, which is associated with the 15 to 20% chance of complications and about 3% chance of dying? Because you can see the curve here. These are the patients that don't have any surgical resections or curative treatments, whereas this survival is much better when they do. And There have been several single series of a lot of centers, big centers that operate more than 100 cases, and they all have concluded that the 5-year survival rate ranges between 18 to 46%. Some of them, such as a German group and the MSKCC, which have about 1,000 cases, offer a survival about 36%. I know it seems grim to you, but for instance, pancreatic cancers, 5-year survival is only about 20%. So in all hepatobiliary malignancies, the outcome isn't very good. Okay, so this is not bad. And we're talking about stage 4 disease. So anyone who has liver metastases from a bowel cancer is actually stage 4. About 10 years ago, that was less than 10% survival. So we're making a lot of progress in this matter, and it's mostly chemotherapy that has made a difference. So what are the strategies and what are the types of colorectal cancers we deal with? Only 10% are offered an upfront treatment or upfront surgery. And as a surgeon, when you look at colorectal metastases, you look at what we can achieve. It's not how much liver we remove, it's how much we leave behind. And that's what we mean by sufficient future liver remnant. We have to attempt removing all tumors, not just leave half behind, because that's no good. And whatever we leave behind, we have to make sure blood is going in, blood is leaving the liver, and your liver produces bile. So we have to ensure that there's adequate biliary drainage. I won't go into details with the indications for chemotherapy, but a lot of patients in Newcastle get chemotherapy first. And what that does is that helps you prognosticate the disease, because almost 40% will progress on chemotherapy. And what that means is no matter what we do, the patient's outcome will not be good. But there's several centers, including Leeds, that offer an operation prior to giving chemotherapy. There's no right or wrong, to be honest. And how we decipher or how we decide who will have an operation upfront is two majors don't work together. So if the bowel is a major operation and the liver is a major operation, the answer will be no. Go ahead and have chemotherapy. But if you have a major liver operation with a minor bowel operation, we might think about doing an operation at the same time before giving chemotherapy. Or the other way around, you have a minor liver resection and a major bowel operation, and we think about things. The reason why we do restrain from giving more chemotherapy is because chemotherapy damages the liver eventually. And when you operate on it, it increases the chance of dying, bleeding, and post-operative complications. So although it prognosticates and helps control the disease, it does damage the liver. So the more chemotherapy given, the more difficult it is for us to offer an operation or a higher risk of surgical complications and worse outcomes for patients. So it's that balance we need to achieve in order to get a good survival and get to a curative operation without causing too much risk. But again, that's only in 10% of our patients. So we're looking at a very small number here. Double the amount is those patients which are by definition resectable, but there's some technical challenges, such as they'll be involving certain structures that we cannot remove, and you need to give chemotherapy in order for the tumor to shrink, and so we can go ahead and do something. Or they're scattered throughout the liver, but potentially we can pick them off at some point of time and still offer a cure. And this is called conversion chemotherapy. And what that means is from a disease that is unresectable, you're converting it to something that is treatable. Now, surgeons are funny people. The definition of resectability is very ambiguous, and the Dutch have got us on this. And what they have done, the Dutch people, they went through a lot of colorectal cancers are referred to us via a district general hospital. So we are the tertiary referral center. What the Dutch have done is they've gone to separate centers, 24 centers in Netherlands, brought the scans of patients that were given chemotherapy and were deemed unresectable in the local MDT, which is a multidisciplinary meeting, and gone through all the scans by HPP specialist. And about 29% of them, that's almost close to a third, were actually treatable before they were given chemotherapy. And surprisingly, 70% of the surgeons who looked at it had different plans. So that's how tricky it is, because everyone has their own opinion and strategies. There's no one strategy. There are many ways to skin a cat, basically. Unfortunately, 70% are unresectable, and this is where liver transplantation outside the UK and within the UK comes into play. And when you have multiple disease sites, like in the liver, lung, and bone and elsewhere, that's not an inclusion criteria for liver transplantation. Poor performance status, which means someone who's not fit enough, again, they will not be suitable for liver transplantation. But it's the second one, when you have what we quote as unresectable disease, when all segments, all parts of the liver are involved with tumors. And most patients get palliative chemotherapy, and that's about 70%. So again, we're looking majority don't get curative treatments, which is quite unfortunate. Now, liver transplantation has been going on in the UK for quite some time. It's almost restricted to cadaveric donors, which is patients who are either brain dead or what we call circulatory death. Only Leeds and Kings do live donor transplants, but not in big numbers. The Middle East, Far East, and Southeast Asian countries have a low cadaveric uptake, but a very high rate of live donor transplantation. Most centers do about 200, 300 a year in the Middle East and in Southeast Asian countries. In the UK, it's predominantly for alcohol-related disease, autoimmune disease of the liver. And please stop me if you have any questions. I'm happy to answer them. Primary biliary cirrhosis and primary sclerosing cholangitis, which are, again, autoimmune diseases that affect the liver. PBC is also known as actually primary biliary cholangitis now, but that's when the liver gets damaged, whereas PSC is when the bile tubes get damaged, or the bile ducts. And then, of course, you have hepatocellular cancers, which occur in cirrhotic livers mostly. It's very unpredictable. There's now a transplant benefit score, where it's who's going to benefit the most from getting the liver. So when there is a retrieval or an organ retrieval, there's a scoring system, and whoever's sick enough or very sick will get the liver that has been offered. And unfortunately, a lot of times, the patients with hepatocellular cancer are not sick, but they are given a few more points, but they're still not very sick. So it is an unpredictable wait time, and the predicted survival is about, in 5 years, is about 50%. Now, my main interest was transplant oncology, and this is what it looks like. Milan has published several papers in which patients with cirrhotic livers and hepatocellular cancers, there was about 60 to 80% survival in 5 years when they had a liver transplant, and it was way back in 1996. So if you see the top half, that involves patients with liver cirrhosis. In 2017, people started transplanting for cholangiocarcinomas. In the UK, we do offer it, but for centimeters, 2 centimeters or less, which is tiny. So we're not going to get many patients for that, but they have to have a cirrhotic liver. And in non-cirrhotic livers, America performs a lot of transplants for perihilar unresectable cholangiocarcinomas, but it's a very stringent process. It takes almost 6 to 8 months for someone to get a transplant, and they undergo a lot of chemotherapy, radiation, quite a few operations just to get to a transplant. But the results are very good, but it's not been reciprocated anywhere else. The Milan team also do transplants for neuroendocrine tumors. The results aren't out yet, but it's not very good. And the next criteria here is what we're looking at is the Oslo group. It's called the SECA trial, which is SE is for secondary and C is for cancers. So that's how they've shortened it. SECA trial is the Oslo group, where you have non-cirrhotic livers and unresectable colorectal liver metastases. So the first unsuccessful attempt was in 1963. That's you. The feasibility was demonstrated in 91, but mostly abandoned in 95, and I can tell you why. The results are really bad. The overall outcomes, as you saw earlier, for transplant should be at least a 50% 5-year survival. The outcomes are quite dismal, so it was stopped. But because they have surplus liver donors, the Oslo group decided to give livers to patients with unresectable colorectal liver metastases. The initial trial, which is known as SICA-1, they were quite, I would say, flexible with the criteria. They did 21 transplants. The primary tumor, which is the bowel, had to be out. So the patient had to have his bowel surgery first, had to have an unresectable colorectal metastases, and only 6 weeks of chemotherapy. And they went ahead and had a transplant. The outcomes all are quite good. As per standards, as you can see, the survival was 60% at 5 years, which is, if you look at it, better than an operation for resectable disease. They thought they could do better. So they went ahead with more stricter criteria, and it published in 2019 and 2020, where they waited a year from the time of diagnosis to the time of transplant, and the patient had to be on chemotherapy with a reduction in the tumor volume by about 10%. And the survival improved even more to about 83%. Now, most patients that had recurrence were in the lungs, not in the liver itself, which is quite promising. But of course, they're the only ones who have done it. So we're stuck with one center with numbers, but not as big as numbers that we would like. So complicated slide, I'll go on to the next one. And this is the criteria that we have, the liver advisory group came up with by Krishman and Raj Prasad of Leeds and Krishman of Kings. And it's, of course, we've looked at the SICA 1 and 2 and tried to be a little more strict because we can't afford to give livers to everyone. So we have to limit the numbers. So inclusion criteria, it's quite vast. It's about the primary has to be out. Sorry, my dog is interrupting. So it's a mini sausage. It has to be an adenocarcinoma, the various types of colorectal tumors. The third point is basically they need thorough investigation. So CT PET is to look for disease elsewhere. We wouldn't transplant anyone who has disease outside the liver. It has to be only within the liver, and the primary has to be out. And what R0 means is basically the tumor has to be resected in totality. There should be no microscopic or macroscopic disease of the bowel remaining behind, which sometimes gets a little tricky because you have patients who have quite major operations and there are few cells left behind that they will not get a liver transplant. We're quite strict with these criteria. It has to go through one of the colorectal MDTs, which is local bowel surgeons MDTs. In Newcastle, we attend the hub and spoke. We go to the local VGHs. So there's always an HPV consultant at most centers. And that's where we shortlist patients, or we highlight patients that will probably benefit from an operation and bring it to Newcastle. So they then have to be discussed at the regional NDT, and then it's the national NDT. So once we highlight a patient for that might be suitable, it has to go through the transplant assessments meeting and then a national NDT. So quite a long process. It's long, but the patients have time, and unfortunately, they have to be stable for 2 years on chemotherapy, which is a very, very long time. And as far as I know, there have been only about 4 cases that have been operated upon since 2022. So chemotherapy has to be given for about 2 years. They have to remain stable. If they progress and a new chemotherapy is started, unfortunately, the clock is reset, which means they have to wait another 2 years. And I'm afraid to say that's not going to happen. It's quite a strict criteria. They have to have recent imaging within 6 weeks of being listed, and then it goes to the national NDT, and we decide whether they'll be suitable for a transplant or not. So I must say, we have highlighted lots of patients in the past year and a half at Newcastle, but unfortunately, we've done only one, and the rest 5 or 6 have progressed either in the liver or elsewhere. And one of our patients had to have the bowel removed and unfortunately progressed off chemotherapy. So it's very, very tricky. The only thing we do is we highlight them very early in the process. So if someone is unresectable, fit, young, what is not mentioned here is the age should be less than 60, but that's a flexible criteria. So if someone is very fit and well and can get through a transplant operation, I think the maximum would be 70, but we can appeal a bit for patients in that age criteria. But quite complex. It has to go to several MDTs. We find it sometimes very tricky to get the bowel surgeons to operate on someone with a liver, which is possibly not going to come to a cure. This is an unnecessary operation, but we wouldn't know until they get chemotherapy. So there's a lot of barriers, and I think we aren't there yet. And the 4 cases we've done, it's been in the last 2 years. They're still alive, but we've done only 1, and he's doing well. And I think Kings has done 2 and Leeds has done 1, so there are not many numbers. Still a long way to go, and we're hoping that this is just the exclusion criteria. So basically means those who are not eligible. So if you have disease elsewhere, if the bowel is still in, the primary cancer, and if they have other cancers, or there's a tumor marker called carcinoembryonic antigen, if that's rising, means there's disease somewhere and we can't see it, they are excluded. So, as you know, very select few patients. There's even to come to an operation, it's only 10%. So we're looking at very, very small numbers. And we're hoping we'll relax it, but we need to do a few more. So it's not the best news, but we're getting there. Thank you.
Thank you very much. That was really interesting, very fascinating. Just illustrates the challenges when someone has stage 4 cancer. So does anyone have any questions?
No.
Yvonne?
Do you have any questions?
Hey, thanks, Rohan, and thanks for your precious spending your precious time with us on a Friday evening.
No, not at all. No.
Thank you. And I think I did hear a little dog there, didn't I? Did you say it was a mini
Dachshund? I called it a cocktail sausage. So.
Oh, yeah, because they can be quite noisy, can't they? Yeah. But Rohan, on slide 8, can I just ask you, your slide 8, you had a list of types of liver disease.
Yes.
Yeah. What I noticed on that slide, you didn't have the liver disease that I would have expected to be on there, which was MASLD, or formerly fatty liver dise's.
Yeah, I mean, I just didn't put it in. I didn't put it in, but it's there. It's there. That was just a brief of things. Now, MASL disease is going to come down with Mounjaro, to be honest. So the bariatric surgeons are already complaining. So I think things are going to change. They do have side effects, obviously, but the GLP injection is going to change a few things. Again, it'll be years to come. But you're right, MASL disease is one of the main ones too. So the many causes of cirrhosis, the list goes on and on, but I just put a few.
Yeah. Okay.
Thanks for reminding me. I'll put that one in my next presentation.
Yeah.
So.
Yeah, it's the one that is sort of you immediately think of as times moving on. You know, am I right in saying that you thought because of the Mounjaro, the liraglutide injections and things like that, that's going to be less of an issue? Did you say?
The obesity surgeons have seen a drastic reduction in their really? Numbers. So right. Eventually, I think it's not going to reverse fatty liver disease, but I think the incidence will reduce.
Wow.
I'm hoping so too, because it's quite a preventable thing. So I'm hoping it would.
Yeah. Okay. Thanks. Thank you. Yeah. Fascinating.
Do you have questions?
Yes,
you're right.
Yeah. Can you hear me?
Yes, we can. Yeah.
That's fine. You mentioned there were, I think, 11 criteria there in terms of the guidelines, and at the end you said that there was going to be a likely relaxation of criteria eventually. Which criteria do you think will actually be relaxed?
That's the problem. So I know for a fact that the first criteria, which means the primary tumor has to be out, and completely resected is never going to change, because that is a direct prognosticator of disease and local recurrence. The things that can be relaxed is probably the time. So if you see the SICA 2 trial, it's a year. We've doubled that to 2 years. And I'm not sure why, because we are reducing our numbers by saying 2 years, but I think we have to be very careful. And by doing 2 years, what we're relatively doing is prognosticating those patients who have lived long on chemotherapy, so the biology of disease is not as bad. That's basically what it is. We can't defeat the disease eventually. We can only grade them, you can put it that way. So if they live 2 years on chemotherapy and are stable, then well, they'll do well with the liver transplant, is what we're looking at. And I think age is a flexible one. We already appealed for a 70-year-old, but it is 60. But I think that's no bar anymore. You know, it won't be 80 and 90 for sure, but at least initially, they will increase the age too. But the rest is very tricky. It has to go through all the staging processes and things. So I think the rest wouldn't change. Now, a lot of countries exclude patients that have bad molecular biomarkers. Colorectal cancer is actually quite, there are a lot of markers such as KRAS and BRAF mutations and things, which are bad prognosticators. So they exclude patients with that. The UK hasn't included that yet. Although we know they don't do as well, we haven't included that yet. So I think that might come into play too. We might relax a few and add on a few too, you know.
Right. Excellent. Yeah. Thank you.
Anyone else? Yvonne.
Sorry, just looking at age. Are you just looking at the other end of the age line, if you like? Are you seeing many young people or younger people coming through needing this type of work, Rohan?
I can't pinpoint any age, but unfortunately, younger patients have more aggressive disease.
Right.
It's at least that's what we think. They come with a nastier disease and things. But again, they're more likely to get through chemotherapy for 2 years. They're more likely to get through a transplant rather than someone who's older. So it is, I wouldn't be able to pinpoint any age that, but the older patients tend to live a little longer with the disease.
Okay, yeah, got that. Yeah, thanks.
There's a lot of things like right-sided colon cancer is worse than left-sided colon cancer. Then you have a lot of these, like I said, molecular biomarkers and things. And then there are a few staging prognosticators and things looking at tumor markers. Synchronous disease is worse than metastasis disease. So those who present with bowel and liver cancer, they have more aggressive disease generally. And that's why we tend to give them chemotherapy first. Whereas metastasis disease, which means if someone's bowel is out, they've had the operation and they develop cancer in the liver 6 months following that, it's known as early metastasis disease. And if it's a year after, it's known as late metastasis disease. They are more likely to get an operation rather than chemotherapy. So in these patients, you would probably give chemotherapy if it's a really large tumor involving major structures or a tiny tumor involving major structures. And to reduce the complexity of the operation, you want to give chemo and shrink it. That's about it. The different modalities of treatment now, there's surgery, of course, but our intervention radiologist colleagues are taking half our work away from us. Now, again, the Dutch have published that there's something called microwave ablation, where if a colorectal cancer is less than 3 centimeters in size and less than 5 in number, they are burnt with a needle via the skin. And the outcomes are similar to an operation, but the patient goes home in a day. It's more cost effective, and there's less waiting times. So you're looking at other modalities coming in, and it's only going to get better.
Yeah.
So we're just describing the nanoknife there.
No, so NanoKnife is something called irreversible electroporation, and unfortunately, it's not licensed for colorectal cancers. We do use it, but it's not a NanoKnife. It's known as microwave ablation, and we do in Newcastle. We have a very good team that offers this service, and it's brilliant. In all honesty, I would want a microwave ablation rather than an operation, especially for the selected criteria. You have the ablation, you can go home the same evening or the next day with a few needle pokes. That's about it. The complication rate is tiny, less than 5%, and the effectiveness is the same. So it's much better for the patients, basically.
You mentioned that I think you said it took between 6 and 8 months to actually get a transplant. Is that improving, or is that going the other way?
No, well, they have time. The thing is, what we have to do is identify these patients very early. So we obviously learn too. We learn from things. Our first patient, when we identified, was relatively late, and again might have progressed before we had listed, or it was slightly, I would say, we should have listed them at the time of presentation rather than after the chemotherapy and things.
Right.
So now what we do is because the oncologists don't send them to us either if it's unresectable disease. They just keep giving chemotherapy. We have, I wouldn't say educated them, but we've had these Northeast meetings about colorectal cancers trying to explain these are the outcomes. So kindly refer if you think someone is going to fit the criteria and things, because not everyone knows it, basically. So that's it. I think it's identifying these patients early is very, very crucial. Because they have 2 years anyway on chemotherapy. So there's no delays as such because they have 2 years to go. But at least if they're identified early, after 2 years, if they still fit the criteria, it's a lot quicker.
Thank you.
Anybody else have any questions?
Yes.
Yeah, me. When you look, you've got 11 and
It's a lot to take in, isn't it?
Yes, it's a lot.
Yes.
yeah,
It is. It's a lot to take in. Yeah.
But unfortunately, the cancers I deal with, almost, as you see here, 70 to 80% are not treatable. So I'm getting good at giving bad news, unfortunately, but that's just the lay of the land. You get patients that come to you that don't have a very good outcome.
Yeah.
We're getting stricter with colorectal cancers. Sorry, go ahead.
I think screening is probably the answer. People are screened for rectal cancer. That might assist things.
That might assist things. We do a lot of surveillance scans. For instance, if we've operated on someone who has liver cancer, the Americans, the Europeans, the Asians, we all have different ways of following up patients, such as clinical examination, blood tests, and CT scans and MRI scans. And surprisingly, the Americans are a little more, how do you say, they laid back with imaging. The outcomes are the same. So you just can't defeat the biology, unfortunately. That's what we're getting at. And even if whoever's identified early, they're very marginal gains. I know for that patient it's good, but you have to look at if you're going to scan 170,000 patients a year just because you're going to catch one, it becomes very, very tricky. The system will just break down. So those are the things. We scan quite aggressively at the Freeman Hospital for colorectal cancers. It's every 3 months initially and 6 monthly after and things, and we follow patients up for 10 months. But again, it's a big area. It's Cumbria, Stockton to North Allerton, and so people do get lost in the local hospitals and things. So it's very, very tricky. We try by doing these outreach hub and spoke clinics and things, but again, it is tricky. It's a big area to cover.
Mhm.
Okay, I'm going to
Right.
stop the recording now, okay?
Mhm. Yeah.
Yeah.